Hi, good afternoon, everyone. I would like to thank Dr. Susan LeBlanc and the Focal Ultrasound Foundation for their kind invitation to talk to you today about liquid biopsies and brain tumors, strategies for the BLOODPAC to lead the field and improve the medical care of this underserved population. I'm Dr. Manmeet Ahluwalia. I serve as the Chief of Medical Oncology, Chief Scientific Officer, and the Deputy Director of the Miami Cancer Institute that I joined last year after serving 15 years at Cleveland Clinic and the brain tumor program there. We all agree liquid biopsy plays a central role in management of a patient with cancer. Applications of liquid biopsies include early detection and monitoring. And once a patient has diagnosed, it can help us pick targeted therapies. It can also help us pick predictive biomarkers, that is, those patients who will respond to therapies. And then more importantly, as we do serial liquid biopsies, we can look at mechanisms of resistance and those mutations as they arise, and then change therapies as needed to continue the care of our patients. We also know that immunotherapy has really transformed the space of oncology and patient care in the last decade or two. And liquid biopsies can help us immensely in predicting response to immunotherapy. But also more importantly, we know when we use immunotherapy in patients, we can come across as phenomena described as either flares or pseudoprogression. And liquid biopsies can help us distinguish that. So on the left-hand side, you see this paper in Nature Cancer, which looked at personalized circulating tumor DNA analysis as a predictive biomarker in solid tumor patients treated with pembrolizumab. So those patients who had a decrease from baseline, here you can see, had a better overall survival compared to those patients who had an increase from baseline. Now on imaging, sometimes this picture is not as clear. And hence we also have data from other analysis showing that trafficking circulating tumor DNA can help pick patient-specific somatic mutations, which can help differentiate from progressive disease from pseudoprogression that may arise in different kinds of solid cancers when you treat them with immunotherapy. And that can predict treatment response with very high rates of accuracy. But what's the challenge in our field? The problem that we face when we treat patients with brain tumors include drug delivery. And a big challenge for that is blood-brain barrier. And that is the same challenge in picking circulating tumor DNA or cell-free DNA in patients in plasma or blood in patients with brain tumors. So on the left, you'll see this effort of over 400 patients with glioblastoma and other primary tumors, which was led by one of my good friends, Achal Singh Akrol, along with Santosh Kaswari at University of California, San Diego, where they showed that up to 50% of patients, they could find detectable circulating DNA with genomically targetable off-label or clinical trial options for patients. Now, this was higher than some of the predicted numbers before them, but still presented a challenge that you can see on the right side now, that glioma here is one of the tumors which has least frequency of cases with detectable circulating DNA. As you can see, there are other cancers where we do much better. So there is work to be done. So overall, sensitivity of circulating DNA in tumors is less than 50%, whereas in systemic cancers, this is more than 90%. And the challenge here is blood-brain barrier that limits the shedding of circulating DNA into the bloodstream. And hence there is a poor or limited signal to noise ratio. And we need to fix that if we want to make this a step or a test in routine care of our patients. So we all know that the unmet need in brain tumors is personalized medicine, which requires routine invasive biopsies. So the Memorial Group actually looked at tracking tumor evolution in gliomas through liquid biopsies of cerebrospinous fluid. And what they concluded was that CSF sampling with lumbar puncture did not produce a higher rate of liquid biopsy than plasma sampling. Both the rates are close to 50%. And we need to be better than that if we want to approach the 90% plus rates we've seen in other cancers. The conclusion of this paper was the ability to monitor evolution of glioma genome through a minimally invasive technique could help us advance clinical development and use of genotype-directed therapies for gliomas, which is one of the most aggressive human tumors, as you know, with dismal outcomes. This have been a couple of efforts, so I'll look at the first from the Mass General, which is on the left side. And this was blood-based biomarkers for diagnosis and monitoring of gliomas, work led by Bob Carter and Brian Nehed's group. Basically, what they concluded in this neuro-oncology paper was that there was an incredible need for minimally invasive liquid biopsies to assist in molecular characterization of tumors, which would aid in identification of true progression in glioblastoma. Dr. Bagley and his group has done some groundbreaking work, which he presented as well, where they are looking at distinguish between progression and pseudo-progression as the patients go through treatments. And then Dr. Nad's group also communicated that ability to perform serial liquid biopsies will provide unique opportunities to study the evolution of tumors and mechanisms of treatment resistance and monitoring the mutational changes in response to therapy. We always in oncology talk about tissue is the issue. And on the right, you see this statement from a group of neurosurgeons basically saying that biopsy is needed for recurrent glioblastoma. And this was a position statement by Christopher Davidson Forum investigators. And the proposal was that there is a dramatic but necessary change to use these biopsies for routine management of patients to advance the field. Now, we also know it's the brain space. So it's not as easy to biopsy at every possible opportunity because we know brain biopsies or brain surgeries are associated with some degree of risk of morbidity and mortality. So what's the solution? This is work led by Nils Lipsman and his group from Toronto, and Nils done some phenomenal work looking at focused ultrasound and its applications in treatment of patients with brain tumors and led a clinical trial with temozolomide. And what he and his group showed is something that we discussed earlier, that blood-brain barrier limits shedding of biomarkers such as cell-free DNA into the bloodstream. So this was a 9-patient brain tumor study, which has been presented and published. And basically what it showed was that using X-plate, the amount of plasma detection of free circulating DNA could be increased up to 7-fold. So X-plate can safely and transiently increase the permeability of blood-brain barrier to allow the passage of cell-free DNA for analysis. And this provides an opportunity for a less invasive access to brain pathology. Similarly, there is work from that I'm not sharing today, but based on personal communications with Graham Woodworth and his group at University of Maryland, which is showing that focused ultrasound can lead to transient opening of the blood-brain barrier, which can help us increase the yields of circulating cell-free DNA. So where do we stand? This is the position paper from Rano, where Riccardo Soffietti and I, along with several others, including Patrick Wen and the Rano leadership, had this liquid biopsy in gliomas position statement, which basically concluded that circulating DNA had a higher sensitivity and capacity to represent the spatial and temporal heterogeneity in comparison to circulating tumor cells. Clinical applications include to establish a diagnosis when tissue is not available, monitor the residual disease after surgery, distinguish progression from pseudoprogression, and also predict the outcome. And the next steps include standardizations with rigorous testing in future clinical trials. That leads into segue for what we are doing. And this is a partnership that I'm involved with Achal Singh Akrol and several others at Insight Tech, which is the Liberate trial, which is liquid biopsy with low intensity focused ultrasound in brain tumors. This is building on the exceptional work done by Nils Lipsman and his group and Graham Woodworth and their group. And this protocol will be a study to evaluate the safety and effectiveness of X-plate model 4000 using microbubble resonators to temporally mediate blood-brain barrier disruption for liquid biopsies in subjects with suspected glioblastoma brain tumors. This study population is including patients with suspected glioblastoma on preoperative brain imaging scans that are planned for a surgical resection of the tumor or biopsy within 4 weeks of the study procedure. This is a prospective multi-center self-controlled pivotal trial in patients with suspected glioblastoma. It'll be an unblinded study. We are using a central lab for biomarker of the blood and tissue samples. Up to 50 patients will be enrolled, and we are looking up to 10 sites to conduct the study. The study flow looks like a patient will come, they will undergo screening for enrollment, and they will meet the eligibility criteria. They'll sign the consent form. They will undergo the blood-brain barrier disruption using the XPlate. We will draw a pre-blood-brain barrier disruption blood draw, and then there'll be a post-blood-brain barrier blood draw at 30 minutes, 1 hour, 2 hours, and 3 hours. Safety check will be performed 1 to 2 days later, and within 4 weeks, this patient will undergo a standard of care tumor resection or biopsy as determined appropriate by the treating neurosurgeon. There'll be a tissue collection, and then the samples will be shipped for laboratory testing. The primary endpoint of the study is to look at the ratio of every subject's of their cell-free DNA in the blood sample 1 hour post blood-brain barrier disruption procedure compared to the cell-free DNA present in the blood sample prior to the procedure, to see what's the increase of the cell-free DNA at 1 hour post blood-brain barrier disruption. Secondary endpoint will include the correlations of these patterns of the resected tumor tissue, which will be done within 4 weeks of the blood samples that we'll collect. And we will look at this at the blood sample level at 1 hour, but we'll also compare the other time points as were previously discussed. Key inclusion criteria for this trial includes patients with 18 to 80 years of age who are able and willing to provide informed consent. You have to have suspected glioblastoma based on preoperative brain imaging. Subjects that are scheduled or will be scheduled within 4 weeks for surgical resection, because we want to minimize the time frame of collecting the blood samples versus the tissue samples that will be collected post-surgery. Karnofsky's performance status has to be more than 70. Patients should be able to communicate sensations during the XPlate blood-brain barrier disruption procedure. This trial has now been approved by the FDA and has gotten the breakthrough designation. So we are very excited. And this has been a great journey along with friends like Achal Singh Akrol, and I think will provide a unique opportunity for our patients as we advance the field. So I would like to thank the Focused Ultrasound group for their kind invitation to share our journey. And I would also provide this as an invitation to the BLOODPAC that this presents a unique opportunity. I think the time is now to make a change for our patients. We now have therapies in the clinic that are showing efficacy in other cancers. And I think this is a perfect timing for us to bring it to our patients in brain tumors. And we feel that liquid biopsies will play a central role in that. And focused ultrasound is a way of increasing the yield of these tests. Thank you so much for your kind invitation.